Is on? Okay, there we go. All right, so good morning, everybody. Thank you so much for coming to this session right at the end of the conference. I always feel nervous about the last slot, but sometimes they do that to save it for the hot topic. So I'm hoping that's the reason why. But thank you so much for coming here. My name is Joji Suzuki, and I'm an addiction psychiatrist at Brigham and Women's Hospital in Boston. And I have the easiest job of all the speakers today because I'm just moderating. So I'm really delighted to be able to be part of this presentation with my esteemed colleagues today. You're here to hear about our workshop on low-dose buprenorphine initiation, so making sure that you're in the right one. We didn't have a poster board announcing the topic, so I hope that you're in the right location. I finished my medical school training in 2002, and that was the same year that buprenorphine became available. So I really vividly remember the year leading up to it. My mentors, John Renner at BMC, was really excited that we had this revolutionary new treatment available for treating opiate addiction. And, none of us envisioned that the opioid crisis would evolve the way it did, although back at that time, we still were talking about the opioid crisis, ironically. It was a heroin crisis in many of the urban areas that we felt needed to be addressed. And so what I recall in the initial trainings that we took for buprenorphine was that the induction, oh no, of course, that word was really sort of scary at the time, like buprenorphine induction, what is that? It was highly controlled. We actually wrote the APA published a couple of buprenorphine textbooks, and I wrote the logistics chapter, which is outlining the logistics of buprenorphine treatment, including the induction process. And it was a highly controlled process. We had to write the initial prescription, well, leading up to that, multiple visits with the prescriber and the social worker, and write an initial prescription, maybe for a day or two, maybe up to a week. And it was in-office inductions, 2 hours that they stayed in the office after direct observation of the initial dose, making sure they're not in withdrawal, get a second dose, then go home. And oftentimes a recommendation for coming back the second day for reassessment. And so we kind of think of that as the initial wave of the buprenorphine induction, where we insisted on having this really strict way of doing it. But it became very clear that that kind of a strict induction was really not necessary. And home inductions became the standard of care in the second wave of buprenorphine inductions. Patients should be just counseled on how to do it properly. And it turned out none of the patients ever wanted to be in precipitated withdrawal. Therefore, they actually learned very quickly how to do it appropriately by themselves. In fact, most patients with OUD go through multiple inductions on their own throughout their treatment process. So they became experts on how to do it safely. But really about 4 or 5 years ago, things began to change. We thought we knew how to do buprenorphine inductions. And in the fentanyl era, and I sometimes call this a third era of the buprenorphine inductions, where we thought we knew how to do it, but we learned quickly that it had to change. And it's pretty remarkable in the last 2 years, the low-dose buprenorphine approach, or initially called the microdose approach, despite having not a lot of empirical support. It's even today, most of the evidence base is largely case report, case series level data. There are a couple of rigorous randomized trials currently underway or being planned, but that's it. It's only about maybe a total of a couple hundred patients worth of data available. Yet it's widely utilized in clinical settings across the country. And it's sort of like the bridge clinic model, where not a lot of evidence really supported, but it became widely adopted in the clinical setting across the country. So it's really nice to see that the emerging evidence base around low-dose initiation confirming A, that it's actually a good thing to do, but B, it's not as rosy as people had sort of portrayed it as in the initial days. And just very quickly about the nomenclature, microdose was the initial sort of way it was described, or the Bernese method. But I think there's a movement towards calling it a low-dose induction for several reasons. Number one, it's true, it's actually not a microdose. And second, is it gets confused with the psychedelic microdosing. So when you do PubMed searches, it gets really confusing. And so I think there's a preference to call it low-dose buprenorphine initiation. So I'm going to have each of the speakers introduce themselves, but the order of the speakers will be Dr. Smith. Initially, we'll talk about the basic principles underlying the low-dose buprenorphine initiation. Dr. Sidelnik will follow up with that, providing some examples of the approaches as well as a literature review. And then finally, Dr. Hathaway will present on the clinical applications of the low-dose buprenorphine initiation. And we'll try to cohort all the questions and answers at the end to try to get through all the content. But again, we're delighted to have you here today, and we're looking forward to our discussion today. Thank you. And so we'll start with Dr. Smith.
Good morning, everybody. Let me get oriented here. Okay, so my name is Mariah Smith, and I'm an addiction psychiatrist at Vanderbilt University. I also help run the addiction consult service. So getting to work with my colleagues here on other consult services in their institutions in trying to come up with this workshop that I think is so important because, as our title describes, we do feel that this is now an essential tool for all consult psychiatrists, as well as addiction psychiatrists like myself, in starting to adopt into our practice. So just to start off, none of us have any financial disclosures for this workshop. And a little bit on what Dr. Suzuki mentioned, but our objectives for today are going to be to introduce the principles of a low-dose buprenorphine induction, describe some of the common clinical indications that we have found for this to be really helpful for, describe some of the protocols, titration schedules, and really the most up-to-date supportive literature and data that we are collecting really in live time. And then I identify some of the common clinical case scenarios where this can be really helpful for our day-to-day practice. So we will get started. So for a really brief introduction, and this is really nothing, we all know this at this point, but just to really kind of create the stage for what we're going to talk about, that the overdose epidemic continues to have an incredible impact in our community, with over 100,000 individuals dying of a drug overdose just in the past year. And of course, we know that this is under reported due to the mass majority of overdoses that happen in the community that never get treated or seen. Medications for opiate use disorder, or MOUD, that we know are FDA approved and that we use every day, including buprenorphine, methadone, and naltrexone, have been shown to have a substantial reduction in all-cause mortality, infectious disease rates, and improvement in quality of life for individuals that have opiate use disorder. We know that buprenorphine is considered the gold standard due to its overwhelming evidence and efficacy and accessibility throughout all clinical spaces and institutions. However, like we kind of mentioned and alluded to, due to its pharmacokinetics, conventional induction protocols that require this prolonged cessation of opiate use, as well as the development of withdrawal, it creates some significant barriers in how we get to utilize this in clinical settings. Hold on a second. So again, just to review, the pharmacokinetics of buprenorphine, it is a partial agonist at the opiate mu receptor, which means that it comparatively causes minimal respiratory suppression and no respiratory arrest when used as prescribed like full agonists. It has a very high affinity at the receptor, which means that it blocks other opiates. And then it has a very slow dissociation at the mu receptor, meaning that it stays on for quite a long time, 24 to 36 hours. Because of this, it has a lot of really unique properties that we really like, and we're able to utilize it, meaning that it treats opiate withdrawal, it minimizes cravings for opiates, and it blocks the reinforcing effects of other opiates. And we don't have to worry about that respiratory depression, especially in some of our higher risk comorbid patients. Unfortunately, because of that, it can also bring in this challenge of precipitating withdrawal. And kind of what this diagram shows is this kind of off the cliff potential of somebody that has opiates still in their system when we give buprenorphine. So what does the traditional buprenorphine induction look like? And for those that utilize it in your day-to-day practice, what we have been using so far is when we have short-acting opiates, including heroin or pain medication, that we have to wait the 12 hours or more. Typically, we do it overnight from your last dose of short-acting opiates, and we have to wait until they're in moderate withdrawal, which, like we kind of alluded to, patients know. And I really try to have them be my guide, and they are the experts in their own body and in their opiate use and withdrawal history, and really letting them tell me when they are ready to go, because I guarantee you they have all had precipitated withdrawal at some point and know exactly that is something that they never want to see again. So once we get to that point, we give them a 2 to 4 milligram sublingual test dose. And then after that, as long as they are doing better, then we repeat this process until they get to a total of 12 to 16 milligrams of a daily dose. So that's how we do it. And what are the limitations to that? Well, for one, we have patients that are on methadone. We have to wait until they're at least 30 to 40 milligrams before we can then wait another 3 days for a washout period before starting on buprenorphine. And typically, patients are on way higher doses than 30 to 40 milligrams, right? So to get them down to a safe dose to then stop and move forward in a traditional setting or an outpatient methadone clinic, that could take weeks to do. We also have patients that are in severe pain, acute and chronic pain, and they just cannot even contemplate tolerating just the 12-hour break. Or we have patients that are on fentanyl, and the fentanyl half-life is very, very long, and it's highly lipophilic, meaning that it just takes so much longer to get out of the system. So in expanding kind of on those limitations, or what are the typical clinical scenarios that we've seen that we just really need another way, that we cannot utilize the traditional buprenorphine induction process? And like I mentioned, it's patients that have acute or chronic acute pain and they're on full opiate agonists, and it's either for severe trauma in the hospital or after a major surgery, but they really want to be on buprenorphine for stability for their opiate use disorder long term. If a patient's degree of tolerance or physiological dependence on opiates, their co-occurring pain, or the duration of the required washout period just cannot be tolerated. We have an increased prevalence in fentanyl use in our community. That, I think, goes without being said. And what I tell my patients down in Vanderbilt and Nashville all the time is that, to me, I think heroin is dead. It does not exist anymore. And even if they think that they're using heroin, it is 10 out of 10 times, in my opinion, probably cut or based in fentanyl. And so we're really having to move away from the traditional process to make them safe, and needing to take into account that really we need to just start operating under the idea that fentanyl is what is in their system. Patients that need to require to switch from methadone to buprenorphine while hospitalized causes a lot of barriers, like I just mentioned. But other barriers that we kind of see frequently in hospital settings is that it's either the patient's preference, where methadone is just no longer working for them, for either their symptoms, their sobriety goals, or just the logistics around getting to a daily dosing center. They start to have, or what we find is a QT prolongation in their EKGs, or we start having respiratory depression because of their comorbid conditions, or being in ICU settings where methadone just no longer can be a part of their plan. And then lastly, what is actually coming up a lot lately, especially in my community down in Tennessee, which is terribly unjust and also illegal, but it still is happening, is the substantial barrier of post-acute care referrals after their hospitalization to either SNFs or IPRs with people that are on methadone. We are more and more seeing them not being accepted. And so we very quickly need to switch them over to an alternative with buprenorphine in order for them to continue getting care and also getting to the higher, or the next place in their care from the acute hospital. So what do we do about it? And as Dr. Suzuki alluded to, over the last probably 8 years or so, we've really been able to develop, understand, and create this alternative approach, which is the low-dose buprenorphine induction. As we already mentioned, it originally was kind of called and described as a micro-induction of sorts. And it provides an alternative strategy to avoiding the need to stop full agonist opiates and preventing the need to develop opiate withdrawal before they get on buprenorphine. So in broad strokes, and we will get into the details throughout the rest of this workshop, but in very broad strokes and kind of just understanding the basics of what we're trying to accomplish is that in providing very, very small doses of buprenorphine and gradually increasing the dose over days, we're able to keep on the full agonist opiates because they are slowly being displaced in a very controlled fashion, which reduces the risk of opiate withdrawal and breakthrough co-occurring pain. With this induction method, full agonist can be continued for the duration of kind of this cross titration. And the strategy, in our opinion, is particularly effective and necessary for CL psychiatrists and anybody on any consult service, really, in treating patients that have co-occurring pain, have fentanyl use, are on high doses of methadone, and have limited ability to tolerate the withdrawal process before a traditional buprenorphine induction. So this is just a visual schematic of exactly what I just described for visual learners like myself, of really just this idea of starting very, very low doses, continuing the full agonist regimen, increasing slowly, reaching the therapeutic dose of Suboxone of 12 to 16 milligrams, and then being able to stop the full agonist on the other side. Hopefully, if it's done correctly, the patient is comfortable throughout the entire process. So again, in more of a visual schematic of comparing the two of the traditional buprenorphine induction process on the top and what it is doing to the receptors versus the low dose buprenorphine induction on the bottom. And so you can see on the top where the risk of precipitated withdrawal is quite high because the orange little dots are the opiates on the opiate receptor, and the blue is the buprenorphine. And if you bring on buprenorphine with opiates still on the receptors, it will immediately kick off them all at the exact same time to get on the receptor as replacement very, very quickly, 20 minutes or so later, making the patient feel like they are in severe 11 out of 10 withdrawal versus kind of this alternative approach of over a few days, very slowly, very discreetly kind of replacing each receptor one by one with buprenorphine, and the patient, doesn't really even notice the difference, except continues to feel good.
So how do our patients who are brought into the ER, having gotten 2, 4, 8, 16 milligrams of Narcan in the field, where does that fit into? Because it's done then, right?
Yes. So that is, so you're saying that patients that already come in and that are essentially have been washed out already.
Very good.
Right. Do you guys want to take that?
Where does that?
I don't know if we could answer.
Yeah, go ahead. Of course.
In the clinical applications.
Yeah, so we can circle back to
Yeah.
that towards the end if that's all right. Because we can touch upon that as well.
Great.
Sure.
Okay, so I wanted to kind of start it off with historical context of where did we all start with this? And Dr. Suzuki actually already mentioned it. I kind of consider this like the OG system and the original kind of crew that really worked on this and trying to figure out what else can we do here. And they called it the Bernese method. And they really hypothesized that if we were to give repetitive, very small doses of buprenorphine in sufficient dosing intervals, we would not get precipitated withdrawal. They would start in that the buprenorphine would basically accumulate on the receptor due to its high affinity over time, very slowly kicking off the full agonist opiates. Back then, this was in 2016, they divided 2 milligram tablets into eighths or quarters, and then slowly would give these little kernels over slow titration over a few days until they reached the therapeutic dose, and then would discontinue the full agonist. On the right, you can see that was their proposed original protocol to be used, and this was done in Switzerland. Sure, they had 2 cases back then that were successful, but before that we had 0. So we still took it as a total win. And, even today, we, like Dr. Suzuki mentioned, we still have a pretty small amount of sample size in the literature to show how successful this is. So kind of coming, fast forwarding to present times, what have we had just in the past couple of years in literature that has been incredibly helpful for all of us to try to update and create protocols that are really working, not just for each individual institution, but more of how can we make this work more universally. And so the first one that I have found to be incredibly helpful is by Sean Cohen, that was just published last year in December of 2021 in the Journal of Addiction Medicine, titled Low Dose Initiation of Buprenorphine, a Narrative Review and Practical Approach. And yes, they go into all the things that I've already described, but I think the one part of it that I really appreciate with this paper is that they provide several principles to guide this initiation for providers. And they're outlined here, and it's choosing the appropriate clinical setting. Is it inpatient or is it clinic? Is it, initiating at very, very low doses, gradually titrating, continuing full agonists, communicating clearly and frequently? And that, I think, is just so important because this is still evolving and developing, and I find that it will not be successful if the patient is completely bought into this process and that they find value in doing it this way. Because I need hyper communication between the two of us in order for this to be successful and how they are feeling through the process. Pausing and delaying the dose if we get any sort of breakthrough withdrawal symptoms, and then prioritizing care coordination between not only their next stage in care, but also between the teams. Again, because it's not as familiar with everybody. So we need to be in hyper communication between teams in order to make this successful. The other publication that I have found to be incredibly helpful is actually by our own Dr. Suzuki, that was done in December of 2020, where him and his colleagues did a systematic review entitled Microinduction of Buprenorphine Naloxone, a review of the literature. And they were able to find a total of 63 patient experiences within 18 publications to really describe and kind of collect what is everybody doing that is successful. They were obviously done mostly in the inpatient settings. And they were able to kind of collect and summarize that over all of these different publications, on average, the most successful initial dose was around 0.2 to 0.5 milligrams, and that there were various schedules, but on average, they usually lasted between 4 and 8 days to get to around 8 to 16 milligrams. So with that, I hope I've launched the rest of my colleagues off well into getting into a little bit more detail into how this has been done. Thank you, guys.
Hi, good morning, everybody. I'm Alex Sedelnik, and I'm the director of the Addiction Consult Service at NYU Langone. And so I'm going to be talking this morning about some of the initiation strategies and protocols around low-dose bup initiation, and also some of the review of the literature that's currently out there, particularly some of the large retrospective case reports or case series. So in terms of the evidence for low-dose initiation, like Dr. Suzuki had mentioned, there's really no large randomized controlled trials that are completed at this time. I think there's a study in Vancouver looking at kind of a rapid initiation using split sublingual buprenorphine films, but the results aren't published yet. And so the absence of kind of really firm, robust evidence, there are numerous retrospective cohort studies, case series, case reports describing reassuringly successful transitions to buprenorphine. And there's about 300 cases that I saw in the literature when I was preparing the slide. So, I mean, by and large, the evidence has been reassuring despite the absence of kind of really robust randomized control trials, and shows the potential for a significant clinical utility for patients that are normally more difficult to initiate buprenorphine with. So in terms of the indications of buprenorphine, this is where I get really excited about implementing this in our hospital, because these are kind of common things that happen for consult psychiatrists, things patients we often see in the hospital setting. So one is kind of exposure to high dose or high potency synthetic opiates like fentanyl, and also co-occurring acute pain or chronic pain. So many of our patients in the consult setting, they have serious infections that are complicated by significant pain, or they're on PCAs or other treatments for acute pain, which makes it more complicated to initiate buprenorphine because people have to go into withdrawal and be off of opiates, depending on the type of opiate, 12 to 48 hours. And also kind of co-occurring treatment with methadone can be another indication for switching, for using the low-dose bup initiation strategy. So, obviously tapering from particularly high doses of methadone, it can be really challenging for patients as you keep going it down from, to 20 or 30 milligrams and stopping. In the hospital setting, we have some strategies to work around this, like short-acting opiates, but by and large, people do experience significant withdrawal. And so by using low-dose initiation strategy, you can actually just avoid having to taper the methadone while somebody's in the hospital setting getting acute medical treatment. And I think also really importantly, I think just kind of conceptually, it reduces the need for a patient to go into this traumatic experience of withdrawal. And so really, I'm sure everybody's kind of seen withdrawal here in the room, and it's awful experience for patients. It can be really traumatizing. You feel incredibly sick, and you can see why it kind of drives ongoing substance use, and people spend their days and years trying to avoid that experience. So if there's a way to initiate buprenorphine kind of safely without having to go into withdrawal, I think from a patient perspective, it would make a lot of sense to use this approach. And I think also kind of more so in the hospital setting, if there are kind of contraindications to medical complications to opiate withdrawal. So somebody has, severe cardiac disease, or you're worried about their ability to tolerate hypertension or tachycardia or, significant distress, that can also be another indication when it might be considered. So you can see it's many of our patients that we see on a day-to-day basis in the hospital setting. And this is kind of just a workflow of the principles of low-dose bup initiation based on the article that Dr. Smith had mentioned a few minutes ago. And so the general approach that's been described in the literature identifies a few kind of core principles. So one is, first identifying that there's a clinically appropriate situation. Does the patient have one of those indications for a low-dose bup initiation? And then subsequently, if they have one of those kind of indications, to initiate a low dose of buprenorphine. And so typically the initial dose is somewhere between 0.2 milligrams of buprenorphine to 0.5 milligrams of buprenorphine. And it's also important to recognize that there's different bioavailabilities between the low dose products. So this is it's something to consider when we'll go in the next few slides about the different preparations. So after you initiate this low dose of buprenorphine, there's a stepwise gradual increase in buprenorphine while a person is maintained on their full agonist opiate. And the duration of titration is pretty variable in the literature. It's described, somewhere from 3 days to even 7 days to even longer. And it really depends on a few different considerations for the patient. So some things to consider are like anticipated length of stay. There's some evidence that high dose methadone may require longer titrations. And so you have to really kind of figure out what titration schedule you want to target based upon the clinical scenario. But I think by and large, for the patients that we're seeing, most people are undergoing kind of a more rapid titration unless they're, on high dose methadone or on chronic opiate therapy for a number of years, and you're worried about the number of morphine equivalents they're taking being particularly high. And so while you're titrating the buprenorphine upwards, it's critical to monitor for tolerance with patients and being very collaborative about how quickly you adjust the dose and continue to increase the buprenorphine. And I think that the collaboration with patients is really important because people oftentimes experience some mild withdrawal symptoms and may need to be adjusted in terms of the titration schedule. And so if there are withdrawal symptoms that emerge, and typically it's about a third of patients, I'll go through the literature in a few minutes. There's different strategies you can implement. So one is just to slow down the initiation schedule, so to kind of pause on the increases of buprenorphine. You can also use symptomatic treatment like clonidine and loperamide and Zofran. And then also you can consider using high potency short-acting opiates like hydromorphone or other opiates like that. But it's a little bit more rare using those things. But I think kind of what's more favorable just to pause the buprenorphine titration and reassess once withdrawal symptoms have improved. And then finally, once you've reached a therapeutic dose of buprenorphine or your target dose, and usually the way I think about it is, what amount of buprenorphine is sufficient to prevent opiate withdrawal? Because you're going to be, stopping a full agonist after the completion. And so for most people, that's usually in a range of 8 to 16 milligrams of buprenorphine. So once you reach that target dose, you can discontinue the full agonist opiate, and the person wouldn't necessarily develop opiate withdrawal because they already have a buprenorphine at a dose that's sufficient to prevent opiate withdrawal. And I think in practice, it's more complicated. So patients are oftentimes very fearful of rapid discontinuation of their methadone or their short-acting opiates. So I think people tolerate tapering more gradually a little better, even though they may necessarily clinically would need that. And so the key for the low dose initiation is getting a low dose, right? So how do we get this 0.2 to 0.5 milligrams of buprenorphine? And so if we look at kind of the buprenorphine products, it can guide us in terms of what options are available. So the first option is splitting buprenorphine films or tablets. And so we'll talk about this in a few minutes, but there's issues around manipulating the buprenorphine product isn't really designed to be split. And there's a lack of evidence to suggest kind of stability of the films and tablets if they're cut. However, this is being done consistently in the outpatient setting. So it's not like people aren't doing it. And also patients do this all the time. So it's not necessarily I think we're fearful of it because lack of evidence, but it doesn't necessarily mean that it can't be done. And then the other buprenorphine product that comes in really small doses is Belbuca or buccal buprenorphine. And this is an FDA-approved medication to treat chronic pain. And it comes in really small doses. It's a buccal film. So patients sometimes are more familiar with kind of the administration because they've tried Suboxone before, which would be the sublingual film or tab. The other products are intravenous buprenorphine. So Buprenex is the brand name. And then finally, transdermal buprenorphine. So these are kind of the four formulations of buprenorphine where we can obtain the low dose of buprenorphine needed for those initial doses. So you can kind of imagine that the literature out there right now is largely reflective of different protocols and titration schedules that are based around these low dose formulations. So I'll go through some of the existing evidence that describes the use of these low dose schedules. So the first is this is a study that just came out, and I'll mention a few studies. There's a lot of different case reports and case series out there, but I wanted to include ones that were with a large sample size and were more recent. And so for the sublingual films, oftentimes this is done in the outpatient setting and by patients. And in the hospital setting, it's oftentimes challenging to get pharmacy to approve splitting the films, based upon the concern about manipulating Suboxone films. So the lowest dose that Suboxone comes in is 2 milligrams. There's other products like Zubsolv comes in smaller doses like 1 milligram, but still not low enough to get to that low enough dose of 0.2 to 0.5. So if you take a 2 milligram film and you cut it into fours, you can get 0.5 milligrams, which you could use. In our hospital in particular, we work with pharmacy, and there was a concern about splitting the films, so we couldn't necessarily do that. But there was a large retrospective cohort study that was published recently with a sample size of about 62 patients. And you can see this is the protocol on the right side here. And it describes kind of the titration schedule. And it's a course of about 8 days. And they start at 0.5 milligrams, and they basically double the dose every day. So you start at 0.5, you go to 0.5 BID, you go to 1 BID, 2 BID, 4 BID, and so on. And so the completion rate, it was about 82%, which is very similar to the completion rates of the other kind of large retrospective cohort studies that are out there. And about 39% of patients experience mild withdrawal. So there's not a small portion of patients that are experiencing withdrawal, but not a huge amount that are experiencing, really severe precipitated withdrawal. That seems kind of more common that patients experience some withdrawal symptoms during the initiation process. As Dr. Smith was mentioning too, it's really one of the things that they identified was that patient motivation and confidence in the titration process, they're kind of buying in a way, was most associated with continuation of the protocol. So it's really important to get patients to be interested in the transition. So they describe cases that we've probably all seen where the person needs to be on buprenorphine to go to a post-acute care facility because they're not enrolled in a methadone program. And so patients may be recommended to switch to bupe, but unless they really want to do it, it's very complicated to do it for these patients. Okay, and the next product we'll talk about for the low dose initiation is the buccal buprenorphine, or Belbuca. And it was first described in last year in the Journal of Addiction Medicine by Melissa Weimer. And she talked about a patient that was 59 years old and was on buprenorphine naloxone as an outpatient, and actually got admitted with pancreatitis. And so for whatever reason during the admission, they'd stopped the buprenorphine and they need to reinitiate it. And so there was a lack of ability to split the films. And so they used an alternative low dose buprenorphine product, which is Belbuca. And so she described this kind of 8-day course for the initiation, which started about 225 milligrams of buccal buprenorphine. So I'll talk about our experience next with buccal buprenorphine. So we have a protocol that we implemented in the past year, or a year and a half probably. And based upon this, this case report from Melissa Weimer and a couple other case reports, we're really interested in implementing it in our hospital and kind of clearly seeing the clinical utility for our patients. So we talked about splitting the films. It wasn't really feasible. So we had some discussion with our pharmacy and ended up landing on relying on Belbuca or buccal buprenorphine for our low dose initiation. And that's primarily based upon concerns around cost. It seemed like it was gonna be a bit cheaper in the hospital like that. And also it seemed like there was more flexibility in terms of the dosing. So the other strategies you can use, like IV buprenorphine or transdermal buprenorphine, and there's pros and cons to each one, but we ended up deciding this one. So we have both a long and a short schedule. And the idea was that if patients were on high doses of methadone or had a long history of being opiate dependent, then you could use a longer schedule. And that was about an 8-day schedule. And we have a shorter schedule, which I think we may revise again, because I think it can be even shorter. But basically you start at, we only carry one film of Belbuca in the hospital, which it's good for pharmacy. Also, I think they prefer to not stock a lot of different doses of Belbuca. So we have 150 micrograms, and we dose every 6 hours. And then we increase the dose gradually over 2 days until we get to the Suboxone sublingual film of 2 milligrams. And that's on day 3. And so that's kind of the protocol we're using. I wanted just to mention quickly that there was a virtual symposium by a UPenn group that also is using a Belbuca strategy for low dose initiation. And they described a bit quicker protocol that seems to be pretty well tolerated as well. We actually started a much higher dose. So we were starting at 150 micrograms and they're starting at 450. And so that kind of speaks to how we're not quite sure how, what predicts tolerability. And so some people may be able to tolerate higher doses, some people may not. It's not entirely clear. This is a really, an evolving space to understand. So I have some data from the past year of about 46 patients where we did low dose initiations. We have about 30 more since that time, but just wanted to focus on a few kind of critical things I found interesting in terms of our data that I think are kind of applicable to the titration schedules. So our mean morphine equivalence on initiation was actually fairly low. So 150 morphine equivalents is not a whole lot. So a lot of patients that are on high doses of methadone, in the morphine equivalents of like thousands. So we're starting at people that have relatively lower morphine equivalent requirements. And, by far, the most common indication that we found for the hospital setting was co-occurring pain. So, about 72% of our patients that we initiated this process was for co-occurring pains that couldn't necessarily tolerate a period of withdrawal off of opiates. And obviously, people had different reasons, like multiple reasons to want to do the low dose initiation, multiple indications. So other kind of common indications that we came across were, fears about fentanyl exposure and precipitated withdrawal. About a quarter of our patients we switched because they were on methadone for a longer period of time. And it kind of speaks to the general principle that we talked about a few minutes ago, but about 30% of our patients required some modification in the titration schedule during the process. And that was mostly for kind of mild withdrawal symptoms. So about a third of our patients, kind of similar to the sublingual buprenorphine study, did experience some type of mild withdrawal symptoms. And the average cost that our pharmacy gets excited about was about $50 per course. And so in terms of the withdrawal symptoms, most patients had very mild withdrawal symptoms. It was about 30% of the patients that did experience withdrawal was fairly mild. There was about 22% of people that discontinued the initiation. So of the 46 we had, 10 people discontinued. And by and large, it wasn't necessarily due to poor tolerance to the initiation. It was more related to issues around kind of changes in interest, like they didn't want to try buprenorphine, they preferred methadone or some other option. And so if you look at the kind of the intention to treat analysis, our completion rate was about 78%. So close to 80% of people that we tried it with ended up completing. But if you look at kind of the people actually completed the protocol, if we exclude some of these other people, the completion rate is close to 95%. That's actually a pretty good completion rate overall. And the titration schedule was very short. So compared to some of the longer titration schedules, the average length of the titration was 4 days. So in an environment we're thinking about, length of stay and prolonged admissions, even for patient tolerability, it's nice to have like a shorter schedule. So in conclusion, from our data, we're looking at, most people tolerated the induction very well with the completion rate of about 95%. Although the intention to treat analysis was about 80%. And the most frequent indications are kind of common reasons why people, patients we see in the CL setting. So things like co-occurring pain and precipitated withdrawal. And a lot of people required dose adjustments, and the average duration was about 4 days. So changing gears a little bit. So the next product I'll talk about is intravenous buprenorphine. So there's kind of this alternative way of getting low dose buprenorphine through parenteral administration of buprenorphine. And there's a few protocols here. This is a study that's published recently with the sample size of about 59 patients. And they described kind of a similar completion rate of about 92%, with tolerability as defined as having lack of significant withdrawal symptoms of about 73%. So it seems like around, again, like 30% of people probably have some mild withdrawal symptoms. And I think the advantage of the protocol is that they were able to kind of rapidly transition patients to sublingual bup, typically from 24 to 48 hours, which is pretty rapid in general. I think kind of favorable for the hospital setting. We're really concerned about length of stay. So I think some of the benefits of intravenous buprenorphine is that it has rapid onset of action. So within a couple of minutes, you reach peak effect. You can see tolerability, pretty quickly after administration. And also, with frequent administration of sublingual or buccal buprenorphine, it requires a degree of kind of nursing staff support and also patient cooperation to get medications every 6 hours or 4 hours or kind of whatever you're doing. Because it's easier to kind of administer it parenterally. And then finally, I know Dr. Hathaway's going to be talking about their protocol at the Brigham, but there's a transdermal buprenorphine formulation as well. So this is a study that kind of described a protocol that's used a lot kind of nationally. It came out of Stanford, I believe, in 2019. And it's kind of hard to see, but basically the process is you would, place a transdermal buprenorphine patch, typically at 20 micrograms per hour. And then after 24 hours, you can initiate sublingual buprenorphine at 2 milligrams. And so I think over the course of, 3 days, they would increase gradually with 2 milligram increments of buprenorphine. and get to a therapeutic dose so we could stop full agonists on day 3. So I think compared to the other protocols, it's fairly rapid, and I think it's 1 day shorter than a lot of the different protocols. And I'll let Dr. Hathaway and Suzuki talk about their experience. There was one large retrospective cohort study that was published this year at OHSU, and they described kind of 3 different transdermal buprenorphine schedules. And typically, there's a 70% completion rate in the hospital and about 12% completed outside the hospital. So the person was discharged during the titration schedule. So again, about an 80% completion rate. And the mean duration of treatment was about 7 days. And 30% of patients experienced some type of opiate withdrawal, which kind of mimics some of the prior titration schedules I mentioned before. And I wanted to include this as a resource for people after the presentation, but this is kind of a comparison of the different buprenorphine formulation products and kind of advantages and disadvantages and other kind of other considerations, for each titration schedule. So we're talking all about kind of inpatient formulations and things that can be done on the inpatient side, but of course, this is being done on the outpatient side, probably much more than the inpatient side. And unfortunately, the products that we use in the hospital for low dose initiation to get those, 2 to 0.2 to 0.5 milligrams, they aren't FDA approved for opioid use disorder treatment. So it's really difficult to prescribe transdermal buprenorphine or Belbuca for initiation of buprenorphine. I think there's some movement on this, but right now it's not. You can't prescribe it. It's not FDA approved for it. And so the kind of the default, because you can't obtain those other products for initiation, is to split the Suboxone films. And so there's some people that are doing blister packing with pharmacies, which does require some work in terms of setting it up. But basically, you have the pharmacy split the films and create a blister pack. And I think one challenge is that during the initiation process, people do have to continue full agonist opiates to prevent withdrawal during the initiation. So you have some people that are kind of actively using during the process. And so it's really critical to talk about harm reduction and ways to keep them safe until they get to a good dose of buprenorphine, which is not unlike people that start methadone, right? They go to a clinic and they aren't a therapeutic dose right away, and they're probably still using every once in a while. So between the different protocols, so there's some considerations to think about. So many of the buprenorphine formulations that I mentioned aren't on hospital formularies. So for the CL psychiatrists, it's important to talk to the pharmacy staff and figure out which ones are available and can you split the sublingual films. And if they're not available, which one seems the most the easiest one to get on the hospital formularies. So you might have to apply for it to get approved through your P&T committees. And also, there's multiple titration schedules for every different type of formulation of low-dose buprenorphine. And there's evidence that they all kind of, there are schedules that work pretty well, with kind of similar efficacy with, differences in duration largely, but the tolerability and completion rates fairly similar between these large retrospective cohort studies. That being said, I think we're still waiting on kind of large randomized control trials that provide us more evidence about this. And so, I think one kind of important thing is going forward is to figure out, what factors, both patient and provider factors and the titration factors influence tolerability. So is it purely, how much morphine equivalence a person is on before the initiation schedule? Is it the type of opiate being used? Is it methadone or fentanyl that impacts tolerability? Or is it the speed of the buprenorphine change, like the delta of buprenorphine? So how quickly you introduce buprenorphine and increase get to a therapeutic level? Or is it like a type of product you're using? Is it something inherent to transdermal buprenorphine or Belbuca or cutting the films? That one seems a little bit less likely because you're still using the same, product of buprenorphine in general at the end of the day. Other kind of outstanding questions are when do you and how do you discontinue the full agonist opiates once you reach a therapeutic level of buprenorphine? We can theoretically just stop, full agonist opiates, but is it more preferable for patients or even kind of retention and treatment to taper down opiates gradually? And also critically important is patient experience. So do patients prefer this initiation schedule rather than having to wait to go into withdrawal? And are there ways to adjust our schedules to improve tolerability? And also on the outpatient side, because we lack the FDA-approved formulations of low-dose buprenorphine, I think there's a real kind of gap in our ability to utilize these initiation strategies without having to split the films, which is probably okay for many patients. But I think it's definitely an area that could be improved. Okay, all right. Thanks.
Hello, good morning. Hi, I'm David Hathaway. I'm an addiction psychiatrist. I work on the consult service at Brigham and Women's Hospital, along with my mentor, Dr. Suzuki. So we're going to be talking, or I'm going to be talking at this point about clinical applications of low-dose bup initiations. And I know we've talked a lot about the background and the evidence. I'm just going to make this really practical. Like, how do you get this to work for your patients? How do you explain it to your patients? How do you explain it to your residents, your fellows? By the way, I'm also an outpatient psychiatrist, so there's days when there's no attending coverage for half the day, and I'm getting like a page, halfway through the day trying to make it work. You can do this. This is really quite doable. I hope that's the message that you come away believing, because I think it is really true. So this presentation seems like it's gone by pretty fast, but actually by the end of it, 17 people will have died of an overdose in this country. The overdose epidemic is, if anything, getting worse and worse. And I know many people have seen earlier versions of this graph. This is the latest version. So it kind of shows, if you could see here, this, where that little spike is with the green, it's just looked like we were doing okay, or maybe things had leveled off, and then we just got schooled again, right? Why is this? This seems to be a central, and by the way, step back 1 second. You've just play a little, do a little role play here. So you are a new fellow at Brigham and Women's Hospital. You just step into the trainee room. You're trying to get your pager to work. You're looking at the wall. You're logging into the computer. Email's taking forever to load up, and then you get a page comes through and it says, "We have a patient that's in acute opioid withdrawal down in the ED. Can you help us out?" And so I happen to be on service with you that day. I come in and I start walking you through some of these papers that are right behind the computer that are pinned up on the wall. This is one of those papers that is pinned up behind the computer, and it's basically showing why we are in such a mess with fentanyl. And it shows that, contrary to what I thought for the longest time, fentanyl is a very long-acting, really does stick around for a while. If you notice, that's weeks. Over a week, the fentanyl can still be present in the system. And patients, as Dr. Suzuki had talked about before, they thought they had this figured out. They thought they knew how to start themselves on buprenorphine. We are seeing patients present to the ED saying, "Help, get me back on this." And these are patients that had been able to successfully get themselves on it for years. We've kind of downplayed the importance of opioid withdrawal, I think. We talk about alcohol sedative withdrawal. We think that's a big deal. People do actually die of opioid withdrawal. There are cases, so we do need to take this seriously. All right, so here you are. You're to the rescue. You're the fellow. By the way, Brigham, we get the sickest of the sick. So if it can work there, it can work, I think, with any patient population, because our patients don't just have polysubstance, they have polydiagnosis. They have everything, right? I think this is a good slide just to start with. I usually start with this when I'm talking to the fellows, and that's just to kind of anchor the discussion. And that's to realize that patients will report being in pain, but it's not like they're lying to you. They actually, that's their experience, it's a valid perspective, but it actually is like three things kind of wrapped up in one. The first being the actual pain that they're experiencing, but also, and I usually like to draw it with the dependence layer at the bottom being the bulk of this here. That really is going to require a whole different treatment than the pain. And then the anxiety layer, we kind of address that with what we call verbal Valium. So one problem, and I'm not going to touch on this anymore from the here on out of the talk, but you're going to see this over and over again, is patients will always or frequently be underdosed with full agonist opioids when they come into the hospital. People say, "Oh, look, they're on this huge dose of methadone, like 150 milligrams, right?" And yet you still need to advocate for them to get full agonist opioids. I would say often, usually twice, double the usual amount of opioids that a patient would require who didn't have an opioid use disorder. So I'm going to, for the sake of time, I'm going to kind of skip through some of these that have already been covered earlier, but you can just see here, mild withdrawal is, we assess withdrawal using something called the COWS scale, which I'm assuming probably most people are familiar with. But the goal here is to try to get our patients onto buprenorphine. So talking about our patient that just came into the ED that was just Narcan, right? Get them onto buprenorphine without putting them through further suffering. Half-life is also important. Remember, Narcan has a pretty short half-life, so sometimes people will require multiple doses of Narcan. We want to keep that in mind when we're thinking about all these different opioids as well. This is a graph that I don't think has got as much attention, or tables, I don't think it's got as much attention as it should, and it really shows just how sticky buprenorphine is. If you see, buprenorphine is right there at the top. It has extremely, extremely high affinity. It can bump off pretty much anything, including Dilaudid, but notice Dilaudid is pretty close to it. So if you're struggling, if you need something to help out, sometimes Dilaudid is a good option. Look how low Oxy is, by the way. Notice that it even outcompetes naloxone. You notice that? So we've gone over this before, but here are some of the, I would say some of the three major indications, so the reasons that we've really been struggling with the traditional approaches. Methadone, how do you, and by the way, how do I tell the fellows to do something that is not, doesn't have an evidence base yet and like get away with that? I mean, I think the reason is there's really nothing. It's not really replacing anything for these three indications. We had no approach to get through these things before. So if there was high dose methadone, if there was acute pain, it required round the clock opioids, if the patient just really couldn't stop using. This is a graph that's not coming through very well, but it's kind of a famous paper from Greenwald, but it shows that buprenorphine is very potent. I repeat, everybody's like, are you? That was wrong, right? Speaker was wrong. No, buprenorphine is very potent. Actually, small doses of buprenorphine have tremendous effects. And that is because, and if you think back, buprenorphine was a pain treatment long before it was a treatment for opioid use disorder. And often those treatments would be like less than 1 milligram, right? So see that very quickly, by the time you're reaching 2 milligrams, you've already saturated, approaching half of the receptors. It takes 16 milligrams to double that occupancy. But notice all along the way, you still have that receptor availability, right? You can still sneak in a touch of Dilaudid as needed on top of the buprenorphine, right? Getting back to that analogy of multiple layers. You want to make sure you're treating both the pain and that dependence layer. What we want to avoid is precipitated withdrawal. There's various analogies I've seen at ASAM, other places as well. One of the more vivid ones is the roller coaster, right? So I think everybody can channel your memories from the theme park where you're headed down that roller coaster. And that's what patients will feel like when buprenorphine, the stickiest stuff, right, outcompetes any full agonist, including fentanyl, and you have that precipitous drop. The one I like the best, the one I talk to about with the patients and with the fellows, is the elevator. So if someone was to snip a cord on an elevator that was going down an elevator shaft, that is my analogy for what happens in precipitated withdrawal. When someone gets Narcan, someone's close to 100% activation of those opioid receptors, you give them Narcan, bam, down to 0 or somewhere nearby. They don't wake up feeling very good. So here's the analogy. You can see here, you can imagine a New York skyscraper, 100 floors, and these are the levels of activation, right? So as you take fentanyl, the closer you get to the top here, by the way, that's where you stop breathing. If you reach the very top there, that's kind of where these full agonists are pushing you towards, the more of you take of these meds. Buprenorphine, on the other hand, you could kind of think of that as being on the 40th floor, which is no joke. I mean, 40th floor, if remember, the 100th floor is you stop breathing. The 40th floor is pretty comfortable spot, actually. I mean, that's buprenorphine is, and I think this is one thing I've got from Dr. Suzuki, is it's frequently underestimated in terms of how strong it is and how effective it is in treating pain. And then naloxone there being the ground floor. This is the current MGB, Mass General Brigham protocol in our opioid withdrawal order set. A couple things I just want to highlight here, and kind of getting to that question we had earlier about the naloxone. So you have a patient that comes in, and I would say often it's an infection, an accident, whatever it is that brought them into the ED, they are in need of help, right? The COWS is off the charts. they need help, and it's hard to even have the conversation. So at that point, when I'm seeing this patient in the ED with the fellow, I'll often say, let's just get something on board to get them comfortable. We'll come back and figure it out. And at Brigham, in contrast to Faulkner, it seems, we use methadone. We just throw on a dose of 30 to 40 of methadone. And you can see here on the protocol on the left side here, it shows that patients who receive a few doses of methadone to treat withdrawal may still initiate buprenorphine later in the hospitalization. That is incredibly freeing. So if it's a Friday night, Friday afternoon at 5, and you get that 5 p.m. consult, patient's in acute withdrawal, say, start methadone, see you on Monday. And it works. It works. And you can still get people on Suboxone. But look over here on buprenorphine. One other thing I just want to highlight. I'm not going to talk about this from now on out, from here on in the lecture, but I'm going to talk. But the 72-hour rule. There's a 72-hour rule we think also with buprenorphine. So if someone had their last dose of buprenorphine within the last 72 hours, you don't need to restart buprenorphine. It has a long half-life. It's still there. You can most likely just continue it. So that's another way to get out of a Friday afternoon, 5 p.m. consult. Just continue buprenorphine. Patient already had it yesterday or the day before. So, and then we have this thing, special circumstances. It always makes me smile whenever I see that, because that's actually almost everything now is a special circumstance. And that's if the patient's been exposed to fentanyl, if you're going from methadone to buprenorphine, if you have patients with a history of precipitated withdrawal, or if they need round-the-clock opioid pain meds. By the way, when we say buprenorphine throughout this talk, we're primarily, I think, referring to buprenorphine naloxone or Suboxone or one of those formulations. So here's Butrans, and I think this is kind of a gold nugget that's been hiding for a long time, and somebody finally found it. And that was, if you look in the package insert for Butrans, you don't need anything to do anything special to start Butrans. You can put a patch on, walk away, and not worry about precipitated withdrawal. At least that's, per package insert, been the dogma, right? So we've talked about IV, we've talked about subcutaneous. We're not going to go into that right now. So these we've already talked about, these different indications. I think it's probably the 4th or 5th time we've mentioned in the talk, so I'll skip over this slide. Here is the protocol. Now, if you want a copy of this protocol, you can scan this QR code and download the Brigham protocol. I did not ask my division director if it's okay. So so you might want to do this quick before he pulls the plug on this, but this will allow you to download the BWH low dose initiation protocol. Essentially, you can see there's 2 arms here, the short and the long, so kind of similar in some ways to Alex. By the way, when I was making this protocol, I wanted to make it very simple. I was working with a pharmacist who made me put all the details in, like line by line. But if I had it my way, it would be very simple. It would say, day 1, you put the Butrans patch on. Day 2, you come back and you give sublingual buprenorphine. Done. Like that's kind of how we do it. Yeah, we do have the nurses check cows before and after and that kind of stuff, but pretty much that's it, and works pretty well from what we've been seeing. So here are our initial results. Kind of noticing a trend, and actually it seems like everybody's kind of landing in a similar spot in terms of how this has been working out. But and by the way, this is nothing about tolerability. Patients, another analogy I use is of a plane landing, right? A rough landing is still a landing, right? We can't guarantee there's going to be no turbulence on the way down. But once the buprenorphine's in your system, it's in your system. It's, very long half-life, up to 25, 35 hours. So once someone's on it, they're on it. Most patients, up to 70, 80%, are able to get on buprenorphine. And I think there's some issues too, because like some of these patients will be going to a sniff, and maybe it's a very short course of opioids on the way out, but that otherwise would be reflected in the dark blue column. Just some things that we've been able to do. Pregnancy has always worried me because you never really want to put a pregnant patient through withdrawal. It's just such a bad idea, right? Whereas with Butrans, we can just use the medicine, slap on the patch, and the idea is it's so gradual, just like going down an elevator. Like you don't feel like when you're going down an elevator, you can kind of tell it's moving, but not really, right? You might notice it stops, but you're looking at your phone, you're looking around, you look at people's shoes. Same deal with Butrans. It's like it's doing all the work for you slowly. So we've been able to do this with pregnant patients. We've been able to do it in the ICU with patients that can't even talk to us, that can't even consent, using it for opioid cycling. My colleague, Dr. Rosen, is a big fan of Butrans now. Patients developed on 180 of methadone, all of a sudden has a prolonged QTC, 660 or something, and methadone is no longer an option. What do? You could go to full agonist opioids, but then you have this up and down and wild goose chase trying to figure out whether the patient fluctuating between severe withdrawal and being oversedated. Why not get something that's long acting like methadone? Well, not methadone in this case, but buprenorphine on board to kind of stabilize and then treat on top of that with the full agonist. One of my favorite cases is a case, and this, to my knowledge, is the first ever done on this, where we went from transdermal, Butrans, to sublingual, and then we went to an LAI, Sublocade. Typically, you want to have the patient on sublingual for about a week before you go to Sublocade. We've been able to negotiate. We can get it down to a few days, 3-4 days before we do that. So that's all I got. So I think that brings us to the discussion part. Is it okay if I leave the QR code up? Okay, look at that. Authorization, yeah.
Oh, that was terrific. So thank you so much. Those were really nice review of the low dose induction strategies and covered it really well. I think it's very clear from what we heard is that actually the procedure is it's sort of like the Wild West. Right now people are doing different things. The good news is that actually they all seem to work relatively well. I think that the sobering part is that actually the initial case reports really painted this as a sort of a slam dunk. People tolerate well, no COW score elevation, no withdrawal. This is the safest way to do it. But that's becoming clear it's not true. Standard inductions where you actually have people go through the withdrawal actually will work for a lot of patients. So I'm curious from the panelists, like what proportion of our patients are specifically receiving the low dose induction versus standard induction in your experience? Like, is it still the majority doing standard, or is it now majority low dose?
Yeah.
It takes.
Yeah, I would say that most of our cases now are low dose. So I can't even think about a case in the past month where we've done like a standard induction. I think it's much more favorable, especially when somebody's medically ill, just to give methadone and like David was saying, to start the low dose initiation and not have to worry about a person getting sick and going to withdrawal, because the methadone is going to prevent withdrawal and stabilize them for the time being. So I think I definitely prefer it. I think it's easier on nursing staff and physicians because you can just set the schedule and there's not as much reevaluation and reassessment. So definitely using much more low dose.
Interesting.
Yeah.
And how about Vanderbilt?
So Vanderbilt's in a little bit of I'd say we're trying to get up to where you guys are at. We're still in restrictions of where we have to use buprenorphine sublingual as our only formulation, and that's from regulations from our pharmacy system. They're just intolerant of going to anything else. So we are having to work within those confines, which are longer titration schedules, and it's just not as favorable. So I'd say we're probably 50-50, and if we need to, we actually are using more of hydromorphone or dilaudid bridges to try to make up the gap. So
Right. And that's a good point that, what's also ironic about the low dose initiation is that this came up in the context of fentanyl use. That's where we first heard about patients having difficulty doing inductions because of fentanyl. But the vast majority of cases reported are not about fentanyl. It's methadone or short-acting opioids to buprenorphine. And so getting to your point about ED, the ED, inpatient detox, are the two settings in which you are doing more frequent transitions from fentanyl, illicit fentanyl, to buprenorphine, where actually very little data exists to show that actually is useful. So I'm curious, so regarding that question about ED or, direct illicit fentanyl to buprenorphine transitions, I'm trying to remember if you included that in your slide. In our, cohort, very few.
Yeah, and this came up in a recent talk in Boston, actually. MGH sounds like they're just doing methadone, just like we talked about. They go methadone, come back later, switch to buprenorphine, get the withdrawal under control, come back.
And that's exactly how the detoxes are doing it as well. Not direct to low dose, but methadone, then low dose. Yeah. So I don't know what your experience has been with illicit fentanyl to bupe.
Yeah, same experience too. I think most of our cases are co-occurring pain or methadone, and not a whole lot of fentanyl that we're explicitly doing it for. There are cases occasionally where somebody will describe a history of precipitated withdrawal, and they're like, I don't go to withdrawal after like 3 days, and it kind of raises red flags about fentanyl use. In those cases, you can be a little more cautious, but it's pretty rare. I would say less frequent overall to do that.
Right.
Yeah.
So I don't know if there's a specific, case you're thinking about in terms of the ED scenario.
It's interesting because we don't test for fentanyl. The standard drug screen. Let me take this off. The standard drug screen doesn't cover fentanyl right now in our ER. You have to do the specialized one. But so we have these people who come in, they've had 16 milligrams of Narcan or whatever. I mean, our medics are really aggressive about that. So where would that, so now we have to be thinking about the fentanyl, but where did that fit in then to this whole protocol?
Right. I think the quick answer would be that if they're already in acute withdrawal, then methadone may be the most definitive, but buprenorphine actually may be sufficient. I think one of the randomized trials that is being conducted now is in the ED, where they're giving low dose buprenorphine initiation as an outpatient strategy. I think they're on paper saying don't continue fentanyl, but I think reading between the lines, I think those individuals are encouraged to think about potentially continuing and tapering. But that's a challenge in the ED, right? You don't have necessarily good follow-up after the initial dose. So I think both options still exist, whether it's a low dose initiation or methadone transition. But I don't know if you guys had thoughts about that.
Yeah, like a high dose, maybe.
Macro. Yeah, that's the other thing we didn't talk about. There's a micro dose or low dose. And then people talk about macro dosing, which generally refer to two things, which is pushing the buprenorphine dose pretty high quickly, or during precipitated withdrawal, pushing through with high dose buprenorphine. So is that what you're referring to?
Yeah, I wonder maybe in that scenario, maybe to give high dose buprenorphine, like 16 or 32 milligrams over a few hours, but that's not necessarily a standard that I'm comfortable with yet.
I don't know if you're familiar with Andrew Herring in Oakland. That's what he talks about, the macrodosing in the ED. If they present with withdrawal in the context of the overdose reversal, simply flooding the receptors with high dose buprenorphine, it can precipitate withdrawal potentially, but the high dose buprenorphine will overcome it. So hence macrodosing. So we didn't really touch upon that today. That's yet another sort of iteration of this whole sort of innovation in induction strategy. I don't know if that answers the question. It's all evolving. Yeah, so I think there's a hand back there first.
So a lot of the data talks about the impact of patient buy-in and adherence to the protocol, but I was wondering if you all could comment on physician buy-in, because at a lot of hospitals, there's a lot of stigma against quote unquote those people, and they may not want to keep them for 3 to 8 days or even longer to do this very slow process. They may be like, well, why can't they just put them on buprenorphine now, because like science no longer matters. So
it's a great question. I think you're right. Stigma against OUD patients still is prevalent. So I don't know. I'm sure all the panelists have lots of thoughts to say about that. So
I could comment. We just submitted an article to Journal of Addiction Medicine on this topic, and doing a big chart review using natural language processing, and it looks like stigma is a huge issue. So I wish I had an answer for you. You can confirm it's a problem.
I'll just weigh into that. So the shortest protocol that currently exists is 2 to 3 days for the low dose. But again, not everybody needs necessarily the low dose induction. So that's the tricky part. We don't necessarily have a good way to predict who needs it as opposed to who would prefer it. But you're right. If anything that lengthens a hospital stay, that can be a challenge. But, as long as the hospital teams are able to do standard inductions, that's not a bad place to start. Again, if you can do macrodosing, you can still overcome it. We don't advise it. Actually, we actually don't recommend macrodosing personally, but yeah, I think standard induction still is possible. And one way to distinguish the standard versus low dose is the standard, it's sort of like ripping the Band-Aid off quickly. You might suffer for a period of time, but once you get on the therapeutic dose of buprenorphine, you're good to go. Low dose is sort of like, ripping it off slowly, just like Dr. Smith was explaining. You're still going through the same process, but somehow slowing it down really minimizes the withdrawal that you experience.
And one more. I think one other thing that I am finding in terms of like how do you get the primary team on board is the alternative, and discussing the alternative with them of, well, your patient is being denied all SNFs and IPR placements because they're on methadone, and now you're stuck with them and we can't get them out and we can't get to the next place of care. Or you could wait 6 days and I can resolve this problem for you by getting them onto buprenorphine so they can go to the next place. Or they're on high dose opiates and they are intolerant to switching over to Suboxone and we have to send them home soon and we don't feel comfortable. You guys need to get him on buprenorphine, but he can't tolerate the transition in a traditional induction. It's like, well, the alternative is that you send him home with full agonists in a taper. And they're like, oh, I don't want to do that. It's like, or I can keep him for 6 more days and we can resolve this problem for you. So it really is just speaking with them about, well, it's either or, and I guarantee you don't like the first answer. So let me help you get to an answer that we all like. The patient feels better and it's safer and where it's all a win-win, and kind of education through talking out their options with them. I have been found has been really successful. Yep.
In the important CL scenario of QTC prolongation, I have actually stopped methadone cold turkey and then waited for withdrawal and switched to buprenorphine, and that's highly unpleasant, so obviously this becomes quite important. So what exactly is the protocol you will use? You still stop methadone cold turkey, when QTC is very high and it's life-threatening. Will you follow the same protocol, low dose buprenorphine protocol?
Yeah, so let's have some, I'll just say quickly that that's probably the scenario in which this procedure has been life-saving, because we can truly transition high dose methadone to buprenorphine in a period of about a week. Previously, actually, the only method was, as Dr. Smith described, gradual reduction, then a transition, which is completely painful and unrealistic. The other option actually we wrote about is actually naltrexone-induced precipitate withdrawal, then a buprenorphine rescue. We did that once and we'll never do it again. It was a horrible thing to witness. So this method actually is the only viable way to accomplish what you're describing. I don't know, maybe Dr. Sidelnik?
Yeah, I think in that scenario, it's not very pleasant for the patient and also for staff. But I think, having a risk, so the person has to come from methadone to buprenorphine because of their QTC. And I think the way I approach it is having a risk-benefit discussion with cardiology about providing some methadone, maybe at a lower dose. And if they're comfortable with providing some methadone while you're doing the low-dose initiation, if they're not comfortable at all, which is not necessarily the case, then I probably want to, when you start the process of the low-dose initiation, it's going to take somewhere between 4 to 8 days, maybe longer, depending on how long you've been on the methadone for and how high a dose they're on. So you're gonna have to bridge that gap in some way. You can use short-acting opiates, or even longer-acting opiates like extended-release morphine. But it's not an pleasant experience for the patient because they have this roller coaster of going up and down with short-acting opiates, of periods of reduction in withdrawal symptoms and then like withdrawal recurrence within a couple hours. And it's hard also to match because the morphine equivalents are so high at high doses of methadone. So you need, like 30 milligrams of Dilaudid every 3 hours, and it's just really. It's a lot for hospital staff to work with. Although if you look at some of the injectable opiate agonist therapy papers in Canada, they use hydromorphone for opioid use disorder treatment. Like the doses they're using are incredibly high. It's like 30 milligrams of IV Dilaudid every few hours, and which provides some reassurance that we can, give high doses of Dilaudid, but it's always kind of a scary process. Yeah.
I will just add, remember, there's other things in the world besides opioids that are available in the ICU, and they can be invaluable. So you're going to see Precedex, dexmedetomidine, you're going to see propofol, even in some of these cases, whatever it takes. But you can get that patient through to the other side. And this is one way that can be effective.
Right. And one of the unanswered questions really is, what is the limit of the pre-low dose induction MME total? Can you transition somebody from 1,000 of methadone to bup? There's a lot of questions remaining about that, but so a question up there. David, can you get that?
Yeah, no, they got a spare. Thank you for doing this. One of the things that I get called the most for in my hospital system is a patient who has a history of opiate use disorder. We're a level 1 trauma center. They're in the ICU and they've been on fentanyl and propofol and also a benzo because that's what they do. And I get called because they can't wake up the patient, because whenever they do the weaning trials, the patient goes into this awful withdrawal and there's horrible, difficulties in doing that. Do you have any guidance or recommendations for starting the bridge as part of that weaning process, as part of that general SBT process?
It's a fantastic question. So I'll have the panelists address that.
Yeah, so the person that's the best person to answer that question is Dr. Jordan Brosen, because he does all of our ICU cases where he has assembled like this. Almost all those cases you see, there's like probably like 15 of those cases that are his. So I think that's a great discussion for next year if we can pull it in. Yeah, but he's making it work, and he is very bullish on buprenorphine, and especially not just for opioid use disorder, but also for opioid cycling. So not, people just find the tolerance or the withdrawal is too intolerable. There's just so he'll switch from, say, morphine to Dilaudid or Dilaudid to buprenorphine, and that can be really helpful. I can't comment too much on the specifics except for that we are using these protocols and it seems to be working.
Right, head up there. Okay, can we get the microphone? But David, he still needs a minute.
Oh,
Thank
you
you.
have two.
Yeah.
Hi, thank you again for the wonderful lecture. I called Dr. Suzuki a year ago on a pregnant woman, and he told me I should microdose her. That was me. We videoed. Thank you again. But I guess going back to the ER question, right? So the timing of the consult will affect what we're going to do, right? Patients in withdrawal versus, they're a substance user, get psych, and whatever that means. I guess with the heavy reversal in the field by paramedics, with fentanyl, isn't it still going to reattach to the receptor once the Narcan disappears? So we're going to see another wave of sedation, another wave of potency from the fentanyl. So it's almost like we should start microdosing them in the ER, whether they're being admitted or not. I guess is my question. That's what one place my mind went to.
Do you want to try to tackle that? Well, I'll just quickly say one thing is that was a fear in the emergency room. After the initial reversal, aren't they going to go back into an overdose? Far as I know, that recurrence of the overdose actually is not that common. In fact, it's pretty rare, my understanding. And you're absolutely right. Because of that concern, should they necessarily get a low dose initiation, or are they safe to do is it safe to just do an induction? Their CAL score is like, 15. Can you just do an induction? The reality is most patients in that setting are not going to stick around if they're not being admitted. They're out the door. So our ED's experience is that those patients hardly ever stick around, and they're using as soon as they leave. So I don't know if what others.
And that's the reason methadone makes so much sense.
Methadone's a more definitive.
Just because it's definitive, treats. If they're still having withdrawal symptom, it's not due to the methadone, right? Unlike Suboxone, nobody can blame methadone for precipitated withdrawal, right? So if you're giving that, you just know you need to give more methadone. Get that on board, get them through that period. Yes, how much of this could be just due to the fentanyl seeping in and out of those fat stores at random, very high activity, but kind of random. And that's been the trauma a lot of our patients are experiencing, but also it's been very well treated with methadone.
Yes, if you're giving methadone, they're legal. And then so, they might use again. So, would you treat withdrawal in the ER?
Sorry. With methadone, knowing that they're leaving, knowing you can't write them a script, right? But in Florida, we write Suboxone scripts for patients who are leaving AMA, or, we'll do anything to get them to not use again. And they'll have no follow-up. We can't get follow-up for a month anywhere. So we are giving them their last shot to survive this. So I'm thinking to myself, you're recommending methadone, but I can give a methadone. They go into withdrawal. All they're used right as soon as they get out. On top of methadone, they're not going to expect. I'm not going to give them 40 of methadone, but there will be some increase in time that they may not pharmacologically expect. So it's a very sticky area.
It absolutely is. And as people know, Yale did that randomized trial starting buprenorphine in the ED after an ED presentation versus non-pharmacologic approaches. Those who got the buprenorphine prescription did so much better. So clearly starting treatment in the ED makes a lot of sense, but it's really, getting that implemented is there are a lot of, tricky issues. Some hospitals rely on the 3-day rule to actually dispense buprenorphine or even methadone or short-acting opioids. Even in the US, that's some jurisdictions consider that legal. We don't know that it's true. But actually, so hopefully in the future, we'll have additional low-dose strategies that may come into play. One would be direct to subcutaneous. Dr. Hathaway didn't may say a whole lot, but actually it may be possible to use a subcutaneous injection, Sublocade, or the upcoming Brixadi as a low dose induction strategy, which would be fascinating, which could actually be a game changer in the emergency room. So hopefully in the future, as more evidence, emerges, we'll have even better approaches that are suitable in the emergency room. I don't know if others have thoughts.
I'll just say something about dosing methadone. I feel like sometimes we're too stingy. And if we're really, this is a patient that should stay. I mean, they're going to high likelihood of not doing so well if they leave. I mean, we go to 40. I know some institutions in Boston are even going above 40 in the first 24 hours, although it's tread with caution, definitely. But what is it going to take to get that patient's symptoms treated? Because if they're going to die from this infection, if they leave the hospital, you don't want it to be because of them not getting enough to control that opiate withdrawal symptoms.
Yeah, I mean, again, we heavily rely on hydromorphone and Dilaudid to help the ED patients too, and especially if they're coming in with infection, of really just trying to get their buy-in of, we will take care of your pain, we'll take care of your withdrawal, just hang tight. And it's been really helpful to just bring it back into a controlled setting of knowing the time, knowing how much, getting them as high a dose as they need. If they leave, they leave. But it really kind of brings back the control environment and making them feel really comfortable really quickly. So for places that aren't able to do methadone as readily as others, Dilaudid is really helpful for that exact process.
Yep, back there.
Yeah, I had two questions somewhat related. It sounds like, so you all were talking about length of stay considerations for starting the microinduction, but also talking about how it's reasonable to like send someone from the ED. So I'm wondering how reasonable you think it is to start an induction on an inpatient medical or surgical ward and then like transition to outpatient if they're otherwise medically ready.
Yeah, I think that the length of stay question around the microinduction or low dose initiation rather, it's tricky. I mean, some of these induction schedules are pretty long, like 4 days, 8 days. One thing that was somewhat reassuring is when we looked at our data, the average length of stay for people that were undergoing low dose initiation was actually much longer than the course of the initiation process. So like the typical initiation process was 4 days and the average length of stay was around 15 to 20, depending on which group we're looking at. So I think I interpret that mostly as that these are patients that just in general need long admissions because of serious infections or their complicated medical illnesses. And so it's not too common that you're actually prolonging length of stay with initiation in my experience, because the cohort needs to be in the hospital for longer. That being said, we have discharged people kind of midway through the induction process. And I think having a really clear plan for the patient's follow-up is important, and to make sure that there's some follow-up if something doesn't go right with the induction process. And we have pamphlets we give to patients, or handouts rather, and that describe like the induction process. That's somewhat helpful. I think in the back of my mind, I always wonder when we're discharging somebody kind of halfway through the induction process, is it really worth that extra day? Because you're assuming somebody's gonna get on the buprenorphine, but you really know. And if you wait another day, you know for sure they're getting this medicine that's life-saving. So I tend to err on the side of keeping in the hospital if the teams are okay with it. But I have discharged people kind of midway through with initiation if they really want to leave the hospital and you want to help make sure they get some type of treatment.
I think that's going to really vary across institutions. We generally do not discharge somebody with sometimes it's called the overlap, plus full agonist. Let's say buprenorphine plus, or oxycodone. We generally avoid that. I just reviewed a paper that actually described that being a fairly common outcome. And also on the Oregon paper that I think Dr. Sedelnik really presented, a good minority, I think maybe 20% were discharged with this overlap. Pharmacies actually have a problem with that, at least in our place. They don't want to fill both buprenorphine and an oxycodone. So I don't know how other places are doing it, but it's done. So some people do that as a way to discharge people midway through the induction.
Got it. That's helpful. Thank you. My other question is just about the cardiac risk. You were saying that it's like high risk cardiac folks are like, it's an indication for doing the microinduction. But I guess I was wondering if you could comment. I know there's always that like theoretical risk that we precipitate withdrawal, even with a microinduction, right? So that could introduce more cardiac risk. And how does that compare to like going through a natural withdrawal for the traditional induction in terms of cardiac risk?
You guys want to comment on that?
I guess I might have opened this can of worms with showing the picture of the person dying from, precipitated withdrawal. So I think from what I know, it's mostly like not dehydration has been like the main issue with the precipitated withdrawal in terms of the deaths that have been associated with it. So I think if you're in a monitored setting, it's probably much less risk because they're going to be giving fluids, they're going to be replenishing electrolytes, those kind of things. I think those cases of death, as I recall, discovered long after the fact outside of the hospital.
Yeah, so I think the risks of standard induction on, for cardiac issues, I think it's relatively low, that just as Dr. Hathaway is saying. Actually, there's a review paper that we published that showed that opioid withdrawal can cause Takotsubo cardiomyopathy. And so there are known risks associated with it, but overall the incidence is very low. So again, it's a matter of the slowly sort of, pulling the Band-Aid or doing it rapidly. There are instances of severe precipitated withdrawal reported with the low-dose induction strategies. And at least in one of the cases, people hypothesize the reason is the full agonist wasn't continued. So that's the three pillars of the low-dose, approach: sufficiently low-dose initial dose, gradual titration of bup, and continuation of the full agonist. And so that third piece seems to be an important component to minimize or attenuate any emergent withdrawal, which begs the question, is it actually mild precipitated withdrawal that you're seeing? So we don't know exactly what it is, but so the continuation of the full agonist during that period seems to really attenuate the opioid withdrawal, as evidenced by fairly low COW scores during that time. But even if they went to the standard induction, again, this is, with the fentanyl, things have changed. I don't know to what extent that's coming into play in your population, but if there's a high prevalence of high dose fentanyl use, you may have to wait for a COW score in upwards of 15, 20 before you can safely do a standard induction. And I wouldn't consider that safe at all. One more question, go ahead. Yeah.
I guess from transitioning from illicit use to microdosing, obviously you can't recommend illicit fentanyl. So it sounds like you're saying in the hospital, you're using dilaudid PRN as psychiatrists?
Yeah, it's interesting. This is one of the things in the addiction consult service that fellows are surprised initially. Like, we're managing pain and opioids. In fact, the fellows learn very quickly that's their expectation, is that they actually recommend teams, because the pain service differs to us because they're not comfortable with it. And I'm sure other institutions have the same experience.
Yeah, I mean, I think from illicit use to microinduction, you could do the alternative using methadone, is to stabilize the opiate withdrawal, to kind of bridge the gap in withdrawal or opiate requirements. But yeah, I mean, I think using short-acting opiates is critically important for OUD in the hospital setting. And I think Dr. Zuka is saying, it's an opiate, it's a tool that we use, and we expect our trainees to know how to use them. But I think they're helpful in terms of managing withdrawal symptoms and pain, especially. People have a high co-occurrence of pain and opioid use disorder, so having some familiarity is oftentimes helpful, especially when you're worried about underdosing of opiates due to tolerance and other situations where you really need to be an advocate for patients for using opiates.
Yes, I'll just say I don't put recs regarding specific pain doses in my notes. I feel as a CL psychiatrist, my job is to advocate on behalf of the patient with those teams to let them know that for one, get that MOUD on board, right? That's like your basal thing. If you think of it almost from an insulin analogy, and then those boluses, those are going to be the pain doses, right? And just let them know whatever I say, put your hand over the OUD diagnosis. If this patient was here for without that, what would you expect this patient to require in terms of short-acting opioid treatments? And then whatever they say, I say, double it. And that's usually going to be that sweet spot. And I won't put that in my note, but I'll say it over the phone with them just to let them know, patients with opioid use disorder have increased tolerance and require more short-acting opiates. And that usually gets us into the right spot. One note, MGH Bridge Clinic, I believe, is recommending that people continue using fentanyl for a week after they've started on the buprenorphine. So I know you said clearly, obviously, but some people have even considered this because of this whole question of how fast can you go down on the full agonist.
That first Bernese method paper, those folks recommended the continuation and a gradual taper of the illicit heroin in the context,
I just feel this is where, please go write your congressman or congressperson, because Why can't we use methadone more liberally? Why can't we use full agate? Why do we have to tell people to go use this garbage street stuff, which is killing people left and right? And the only reason is we're using laws from 4 decades ago, 5 decades ago.
A century ago. Yeah.
Yeah, I think that 72-hour. Oh, I think one kind of positive thing, we haven't this implemented at our hospital, but I think there's a new change in rules around methadone prescribing. And so you can dispense methadone for, I think, up to 72 hours, even without enrollment in an OTP. But I think it requires special exemptions from the DA, and somebody has to dispense the methadone physically. So I think there's some movement in the area, but I don't know if you guys have done much with this, but.
Yep. So we use a 3-day rule to be able to administer buprenorphine even without an X waiver through the ED. And then the entire 3-day packet, they can just simply dispense for bup. We're not there with methadone. We're not doing that with methadone yet, but people are. Any other question? Yep. Maybe one more, and then we can maybe after that bring it up front if people have other additional questions. We're delighted that you have so many questions. These are wonderful, fantastic questions. So thank you.
We are trying to get our ED docs and the head of the ED in our hospital is interested in having everybody get these 3-day scripts out of the ED and get ER doctors comfortable with that. The concern in our area, and I would be interested to see how people navigate this, is there's no place for them to go. There are 3 days, and then what do you do?
Right.
And so many programs, I think, are so, you've got to come to therapy first, or you have to be interested in treatment, and or they're too complicated, or they're also using alcohol, and so they don't qualify for our program. And I just wonder if other people are having this issue, because I'd love to try to do a micro clinic in the ED to see people in 3 days,
Yeah.
but we're stuck.
That's a problem everywhere. I think there's certain solutions. In Massachusetts, they required by law that EDs initiate MOUDs in the context of a non-fatal overdose. So that kind of helps. That's why the bridge clinic model expanded so rapidly. The Yale study that I explained, mentioned the initiation of buprenorphine in the ED. Their paper actually really downplayed this component, which is that those who were starting buprenorphine in the ED had a guaranteed intake at the primary care clinic within 72 hours. And if the clinic was open at the time, they would literally do a warm handoff to the clinic. And that allowed for like an 80% linkage rate post-ED admission. But the clinic only agreed to it because they said, we will only manage this patient for 4 weeks. We'll use that 4 weeks to find something longer term. And so this idea of a bridge clinic, so we don't have to own these patients forever. We'll do the intake, we'll do the stabilization, but somebody else has to do the management. And so they're able to demonstrate that linkage rates were extremely good compared to the other arms in the randomized trial. But after the initial phase, the sort of outcomes kind of start to look similar. But the point was that initial 4 weeks, or depending on the program, that bridge model is so useful that gave the EDs a reassurance that they're not just sort of starting this prescription and they're just all overdosing afterwards. They gave some reassurance that there's some follow-up available, some structured program.
Could I just say, question, can you treat opioid withdrawal, alcohol withdrawal, benzo withdrawal, tobacco withdrawal all at once? Yes, you can. We do it all the time. So, and this is what we use along with other things. Concurrently.
Do you guys have thoughts in terms of the EDs not willing to start?
Yeah, I mean, we have the ED bup initiation in our hospital, but I think the follow-up, like you said, is critical. And we don't have a bridge clinic, unfortunately. So, I think our options for follow-up are pretty limited. I think from like a harm reduction perspective, you could argue to prescribe some bup, and hopefully that'll provide some protection in terms of risk of overdose. But it's never ideal. You'd have somebody have a follow-up appointment soon at a bridge clinic, theoretically, hypothetically, but like a lot of places don't have it, per se. But I think, I don't know what you feel about maybe prescribing bup as kind of like a harm reduction from the ED without follow-up. What your thoughts would be about it?
I mean, I would think so. Being on bup is infinitely better than not being on bup, just period. And post-discharge from an ED, especially in the context of a non-fatal overdose, there's a 5% annual mortality associated with that. But the majority of the mortality occurs within 30 days. So that first 30 days after ED visit for a non-fatal overdose is the highest risk time. And so even if you cover during that time, I think there's a benefit, even if they don't end up continuing treatment. I know that's not a satisfying answer. Yeah.
I think there's also interesting data about like non-prescribed buprenorphine be associated with lower overdose deaths and retention and treatment. So even if they're not necessarily being prescribed buprenorphine by somebody, if they're taking it every once in a while, there's something about their use that's protective in a way, which is also reassuring.
Well, I was just going to say briefly in thinking about your question, because we are privileged enough to also have a bridge clinic that we depend on in our system of potentially, even if you were able to partner with somebody in your institution, whether it's an addiction medicine, a PCP, or psychiatry in the outpatient, of even just being your touch person, of just like, we have an understanding that you will try to see these people in order to at least be a pseudo bridge to hopefully then get to that appointment that is a month from now. And at least it's something, and it's a partnership that you can pick up the phone and text and be like, yo, I'm going to send this guy to you. And at least it's somebody reliable. And really anybody that has a DEA that feels familiar, a DEAX that feels familiar enough to do it, I think is at least better than good luck.
Say at Brigham, I think we're doing much better in terms of the linkage to addiction care. What's really lacking in the state of Massachusetts is dual diagnosis. Because if you think through the patients you see this, how many patients do you see that are just straight quote unquote addiction? Don't have any trauma, don't have any depression, few and far between, right? And a lot of these patients really would benefit from dual diagnosis, and it's just the slim pickings right now. So another area for advocacy.
Yeah. Dr. Winder. So maybe the last question, and we can bring it up front.
Sorry to sneak this in.
No problem.
So pre-transplant patients, transplant teams are really skeptical about MAT. What does this mean? How do we deal with this perioperatively? So I have probably 5 or 6 patients who could qualify for transplant, and some young patients who may need retransplant. So how to think about doses of 8 to 16 milligrams in the context of transplant where it can't be planned, where the organ could become available. These are precarious patients, psychiatrically, dual diagnostically, and certainly there's substance risk. Sometimes they relapse on top of it. Our hospital protocol kind of asks to march down the bup dose ahead to overcome. That's how it's written now. That's what we do. But I always feel like I'm exposing them to psychiatric and substance risk. So any guidance there would be helpful.
I could take this.
Yeah, sure.
Yeah. So we rewrote both our transplant protocol in the past 1.5 years, and then we also did the perioperative protocol, making it making the transplant protocol more generous to recognize that you're actually protecting that organ if you have someone on a sufficient dose, an adequate dose of buprenorphine or methadone. So that should be encouraged as opposed to discouraged. And then with the perioperative protocol, just recognizing that there's still a lot of receptor availability, even at 16 milligrams of buprenorphine. So why are we doing this to ourselves? Where we bring people down to like 2 or 4 milligrams, all of a sudden putting someone at risk for overdose. We can still treat pain even if someone's at 16 milligrams. I mean, so I'm happy to put another QR code up another time with those protocols, or just email me. But yeah, totally. A lot of this stuff doesn't make sense why we're doing it the way we are.
I think whether you continue the high dose, drop it down, or discontinue, you can actually manage acute pain if you know what you're doing. And that's the tricky part, right? Depending on the context, there may not be the expertise to know how to manage that. But all approaches can potentially be appropriate for managing pain. So even if they're on a high dose, we don't think that's a barrier for surgical procedures. Thank you so much, everybody. We appreciate that you stuck around, and we're glad we had this discussion. So thank you.